We had the pleasure of sitting down with Karthi Vijayakumar. She's the manager of 6 different residential care facilities located here in Ventura County, California. Residential care facilities, also known as a boarding care, are allowed in 10 different states throughout the nation. So please check your state's social services site for more information. We hope you enjoyed the interview and thank you for watching.
I'm Karthi Vijayakumar. I work in RCFE facility manager.
So this is a residential care facility for the elderly, better known as a boarding care. What makes this different than a large assisted living or a memory care within a big community?
Okay, so here you can see we have all 6-bedroom facilities. So each facility in the daytime we have 2 caregivers. So you can see the ratio like 3 resident, 1 caregiver. So and they will get hands-on help immediately. If they ring the bell, immediately we will go and help them. But if you see the assisted living, the ratio is different. So that's the main difference you can see here.
So there's 6 residents per house, right? And for your homes, are they shared rooms, individual rooms? How are they set up?
Yeah, we have all 6 private rooms and shared bathrooms. So this is really helpful for especially the COVID time. If someone has some infection or something, we can keep them and we don't want to spread the infection. So it's really helpful, the private rooms, and they will get the privacy in their room if they want.
So you're able to segregate each individual person based on, where they're at, but yet they can still come together?
Yes, we want to encourage them to sit together all 3 times meals and 2 times snacks. Then we have an activity coordinator. So when they are coming, so they want to play in the dining area or in the backside patio, so they will sit together. So mostly we don't want to force our resident, but we want to encourage them to sit together. So we don't want to leave them inside the room. We want to bring them, keep them together in the living area or in the patio. So like that, we want to encourage them.
So how would you describe the atmosphere within the home? Since this is a house, a smaller type community, how would you describe that?
Yeah, so you can see outside, it's a house. So that's the reason we won't call patient, we call resident. So whoever living in this house, it's their house. How the way they want to keep their room in their house, the same way they can hang some picture, they can keep their stuffy toy, something, their memories, they can keep it and they can enjoy their life here.
They're able to decorate the home or the inside of their room however they'd like to.
Yes.
Can you just kind of elaborate on the setting of the home?
Yeah, so it's actual 6-bedroom house, how we live in our house. So it comes with all the living room, dining area, and kitchen, backyard. So 6 people live in this facility and 2 caregivers take care of them. How the way they live in their house, like when they want to take some snack or when they want to watch movie together with their family members. So the same bonding, they will get it here also.
The caregivers and the residents really get to know each other.
Yes.
So they start to build a bond of everything from what they like food-wise to what they like to watch on TV.
Yes, so absolutely. They know each and every person. Me and my caregiver knows each resident, what they likes, what their dislikes, and their hobbies. So all the information we can collect, we know now each other very well.
How does that work when somebody's coming to tour the facility? Do you interview that actual person to see if it would be a good fit because it's such a small environment?
So it start onboarding interview with the family members, whoever comes for the tour. I'm explaining how we are giving the care service here. And then I ask a little bit more question about the resident who is coming. Then I'm finding out more information with the resident primary care physician. And I will give the pre-placement appraisal form so they can fill it out, that form. It's just a 2-page of form. It's not that much enough. I'll tell the family members to add a little bit more information. Then I find out what's their hobbies, what's going on. So for me, that this LIC 602A and the pre-placement appraisal, and I'm collecting more information from the family. All three information I'm collecting, I'm making the appraisal form. Then that's the good care plan for my resident. So I'm sharing my information to the caregivers. So that's the way we are planning. And before moving, I always do the pre-placement assessment.
So you come up with a care plan and kind of how to move forward with that individual once they're in the home, right?
Yes.
And then you're able to adjust that by having conversations with the care team here,
Yes.
the caregivers and such.
Yeah, before moving, I will explain all the information, the medical information, and what I got, the paperwork. I want to get the paperwork previous moving, so we have good knowledge about the resident. Then I'll share with the caregivers. All the caregivers needs to know if somebody else coming the newly, so they will get to know before moving all the information.
How do you deal with families? Are they allowed to come in any time? Are there difficult families that you've run into? How does that process work?
We need to treat the same respectful way to our resident, to the family members. So I always communicate with them. So if we do, like, our morning schedule is every day morning, we don't want to change their sleeping cycle. We are thinking our resident is a second stage of babies. So sleeping cycle is very, very important for them.
That's an interesting way of putting it. The second stage of baby. That's true. I have kids.
Yeah.
So I get it.
Yeah, with respect, we want to treat them. So once they awake, depends upon their mobility. We want to go to the restroom and helping them, like toileting, brushing, and if their shower day, we will give shower twice a day. So other days we will give the sponge bath. We will check the full body check. If any changes happen, like bed sore or redness of skin, immediately we will inform to the family. But if they are in any home health or hospice care, we want to inform to them first, because medical treatment is important first. Then the second person, we will contact the family. So that's what I'm doing here.
So you keep the family in the...
Yes, always. I communicate with them.
Everything that you were saying is pretty a high acuity of care type of individual. So it's people that are needing more care than just an independent living person. So for these, RCFEs, these boarding cares, are you looking for that high acuity care? Is that the person that would thrive here? Someone that needs more care? Or is it for anybody or everybody? Or how?
Yeah.
What's the ideal resident?
Yeah. Previously, I mentioned before, every personality is different. So we go with what they need. So I have non-ambulatory people, ambulatory people, and bedridden. So bedridden need different kind of care. And ambulatory people, they need one person assistant. We won't leave our resident alone anywhere else. We want to keep an eye. So emergency means anytime, anything will happen. So that's our motto. So we want to go with my one resident. If they are going somewhere else, my one caregiver always go with them. So if they need two people assistant, my caregiver go with two caregiver go with and take care of them. So it goes with their care plan.
Okay, so this is for people that have probably been in an assisted living and that need more care.
Yeah, some people comes like that. Some people from the family, so they live their daughters or son, they couldn't take care of them because of the personal stuff, or some they are hands full with their personal work. So that people also I'm getting. Not only from the assisted living,
Yeah.
I'm getting from the hospital also and from the family also.
What would be the difference between just hiring a caregiver at home versus coming into a place like this?
So here we only focus all the resident care. If they are coming to the home, it's a lot of distraction for the resident, the caring point of view. So it combined with the household work and the caregiving. But here it's a setup RCFE facility, the board and care facility. So we focus only caring and take care of them. It's more care about the resident.
For the resident, what does a typical day look like?
The daily activities, so Previously, I mentioned to you, we don't want to change their sleeping cycle. Once they get served, we can help them. Then they will come for the breakfast. So we want to encourage them to sit together all 3 times meals. Then once they finish the breakfast, we will do some activities with the activity coordinator, like some board games or card games and coloring. Depends upon what they likes. We will do like this, some other games, and then they will, most of the time, some of the resident family members is coming. It's a family bond oriented facility. So whoever comes, the other family members, they wants to sit together with everybody. So it's really fun for them also, for us also. And we want to encourage them, the visitors coming to the facility. And then after that lunchtime, they will have their lunch. Then some people, depends upon their ambulatory level, they will go walking. Mostly in this facility, I have all the resident is non-ambulatory, so they go walking every day. Or some people is getting physical therapy, occupational therapy. So my caregiver, if home health is assigned physical therapy, occupational therapy, it's once or twice a week. But my caregiver learned from them, so we will give the whole 7 days all the exercise, the activities every day for them also. So they go walking and do that activities in between the breakfast, after activities. Then this one also it's added. After that, they will take lunch and their favorite movie. Mostly here, people like TV Land, some olden days movies or music. They're after lunch, they are watching. And some people wants to take a nap. Whoever wants to take a nap, they will go to the room, they will take a nap. Whoever wants to watch movie, they will watch.
And then
Then-
then they just kind of wind down for
Yeah.
and such.
Then in the evening, small games, or they will sit in the patio and they spend more time chatting. And we want to collect their memories. So every day we want to ask their past life, what happened, what you are study, where you are study, and who is in your family, how many grandchild you have. So those kind of collecting their memories, we want to keep their memories. So it's a gathering time for them.
What is included in the monthly cost to live here?
So we take care of them day morning, day 2 until night. Then the nighttime service also is there. Then after that, we do laundry for them every day, and we change the bedding like weekly twice. Then if they need in between, if something happen, so we will change the bedding stuff, and we make the room ready. Every day we clean and we make the room ready. They will get 3 times meals and 2 times snacks, and they are getting showering like twice a week. If whoever wants every day also, my caregiver ready to give shower for every day. And they're going walking every day. And what else? Yeah, those are the service we are giving.
Is that adjusted as time moves along, as the person's care need goes up?
So we believe if somebody needs more care, it's part of their life. They need that care service. So we won't increase the care service. Like whoever comes like non-ambulatory status, then they go to the bedridden. So we won't change the pricing.
Okay, so people know right up front, this is what it's going to cost based on the 602, the care, the interview, and talking to the family and all that.
Yes.
You come up with a price, and that's the price that's going to be set for the whole time that they're here?
So it's kind of care, and it's their body is reacting. They need a little bit more care. That's fine. Because of that, we don't want to increase.
Can you kind of speak on the licensing, how you become an administrator, how you become the house to become an RCFE, and then how often like the licensing board comes in and checks and all that?
Once we set it up, first appointment we will get from the fire department. So the fire department will come and they will give the approval which room is allowable for the bedridden person. So 6-bedroom facility, we are allowed to keep ambulatory and non-ambulatory 5 resident, and only 1 resident is a bedridden. That's the ratio we need to keep it. So that bedridden room, we should keep the exit door So that's their requirement.
So there's an exit door to the outside.
Yes.
Got it.
And it's reach out to the fire department. If any emergency happen, they needs to come immediately help the bedridden person. So that's the way they will check all over the place, and fire extinguisher, all they will check their rules and regulation. Once it's done, then LPA will come from the Department of Social Service. They have the set of preliminary paperwork. I need to complete that. And for me, RCFE administrator, I need to complete 40 hours in person and 40 hours online courses I need to complete. Then I need to give the exam. Once it's done, once it's clear, I'll get the RCFE license number. So once I get it, then I can apply for the job.
And how often does the person from the state come and, inspect and assess the house?
Yeah, it's annually. They will come once. But if any issues happen, like if somebody fall down, we need to report. And if something happen, any accident or something happen, we need to report within 7 days. So those are the stuff they will come and inquire in between if they need more clarification. So other than that, yearly once the LPA will come and check all the resident and their medication, their care service. They will get the interview with the resident also.
Is there a license for the caregiver that they need to obtain?
Yes, it's a DSS rules. We need to give, they needs to get 40 hours training before the work, and every annually they needs to get 20 hours training. So how the rules, the administrator having like 80 hours, so 40 hours in person and 40 hours online classes, we need to complete and finish the exam. It's valid for 2 years. Then another 2 years we need to continue in the education. So the same thing for the caregivers also. It's a DSS rules.
And it's every year.
Yes. And the challenging point is some resident doesn't want to take the medication. So what my caregiver will do, they don't want to argue with them. If you are giving the medication, some people has dementia or some people have some other problem, they don't want to take the medication. So we don't want to argue with them. My caregiver will come back. Then we will reach out them after 30 minutes. So we will explain to what is the medication, why they are taking. We want to explain to them. Still, if they are refusing, then I will go and talk to them, or the allowable one like family members or the RN will communicate with them, try to give the medication. That's what we are doing here.
So how do you handle the management of the medication for the residents?
So first thing, all the medication, it should be comes from the primary care physician, the doctor's order. Like if you get fever or cold, we can take by ourselves, right? Tylenol or anything. So all the medication, over-the-counter medication also, it should be listed in the medication list. So we have 3 kind of forms. So it's called the day-to-day MAR, the daily medication administration paperwork, then centrally stored, then PRN log, as needed medication. So what we have, the first form is we need to enroll all the medication in the centrally stored. Then what are the medication they are taking the everyday, day-to-day life. So it goes to MAR, and the other medication goes to PRN log. So it comes like each and every medication has the single sheet. So we go with that list, the day-to-day list. We will give the medication to the resident. So and we have some rules. We are not allowed to give any medication like inserting stuff like injection and suppositories. We are not allowed to give. And like if who were in a hospice care, most of the people taking comfort care, so like called morphine, lorazepam, those are the stuff we need to get from the hospice company. It's a pre-filled syringe because we are not allowed to take the medication from the bottle and measure it and give it to we are not allowed to do that. So those are the rules we are following in all the facility.
How do you handle falls and emergencies within the home?
If somebody get the fall risk, we always keep the bed alarm on the top of the bed. So if they are non-ambulatory status, they wants to sit in the wheelchair also. So we want to place 2 bed alarm on the top of the bed, because we have the call button. So if people has dementia, they forgot to press the button. So if they wants to come out of the bed, or if they wants to get up by themselves, then that bed alarm ring for us before they get the next step. My caregiver go and help them. So we protect fall risk like that, but sometimes it happen. So if it's happen, immediately we want to, mostly in that stage, most of the people is in a home health or hospice care. This depends upon the fall. We will take a call. We want to inform to the home health. If they are in a hospice service, we want to inform to them. By the meantime, the next call to the family members. But sometimes if it's the fall, it's happening like head injury or some bleeding or something happen, we will call 911 immediately. We don't want to take a risk because they are elderly people. If they fall down, we don't want to take them because we don't know any airline fracture or something happen. So we don't want to transfer them. The paramedics will come within 5 to 7 minutes. So we will call them immediately. That's the way we want to keep on eye. That's why we want to go with one caregiver, go with the resident always.
For you, what is the most rewarding part about being here, being an administrator, being part of something like this?
Yeah, first of all, I love my job. So I can help the senior people, and they are sharing with me their emotional feeling, their personal happy feeling, not only the resident, the family members also. So that way, I'm really blessed. That's what I felt. And I can help the senior people. I can find them correct place. I want to give them the proper place because we have 4 facilities. Depends upon the care plan, I can place them. So that's the way I felt I blessed.
What do you wish families understood about aborting care and just the overall transition into a place like this?
Yeah, it will take some time to the family to understand board and care facility because they like their lovable ones suddenly they are leaving. It's I can say it's like a transition for them also, how they are keeping their kids at home, then they are sending to the school, how they have that feeling, the same feeling most of the family have it. So they needs to adjust that situation. Then the same way they can come and visiting their lovable one in the facility, and they are getting extra more hands-on help for their lovable one. So that's understanding family needs to get it. So it won't come just like that because we need to earn that. So that comfortable I need to give and my caregiver needs to give it to the family. So that's what I'm doing here.